and all the students, colleagues for this webinar. This webinar has been a very hit series of sessions of neurology, which has covered across most aspects of burning topics in neurology. The last time we had a topic on arterial stroke, which was very well attended, both in India and abroad. And this session is dedicated to venous strokes. And coincidentally, it also happens that yesterday was World Stroke Day, and today is the session on venous strokes. So we have a distinguished and an elite panel for today, and I would like to extend a warm welcome to all the panelists who have joined from various parts of Karnataka. Firstly and foremost, our teacher of teachers, Dr. L. Krishnamurthy sir, joining us from Davangere. He is going to be the chairperson for today's session. He is a professor and head of Department of Neurology at SSIMS and RC Davangere. He was the former HOD, former professor at JJM Medical College. He is trained from BMC Bangalore, and his interest in academics is unparalleled. He is at the forefront of most academic discussions that happen. Of course, goes without saying that he trains DNB students, and he has been a teacher of teachers, as I said, and we learn from him every single day. And he has been active not only in academics, but he wears his passion on his sleeves. So, you know, if we see how he follows ardently and passionately even his interest in cricket, and now his hobby of running. With all this, I would like to welcome Krishnamurthy sir to this session, and I would like him to take over. Just before he takes over, I would also like to welcome Dr. S. Saravanan, who is my colleague from Sagar Hospitals. And further introductions will be done when their sessions are going to start. I would like to welcome Dr. Mayank Srivastav, who is a consultant neurologist at Columbia Asia Hospital. I would like to welcome Dr. Harish, who is attached to Sahyadri Narayana Multispeciality Hospital at Shimoga. I would like to welcome Dr. Dayanand, who is also kind of my mentor, you know, when I just went for my DM training. So he is a consultant neurologist at Fortis Hospital, Nagar Bhavi, and also Yashas Neurocare and Diagnostic Center at Bangalore. Like to welcome Dr. Nikhil Hiremat, who is a consultant neurologist and my colleague at Yeshwantpur Sparsh Hospital. And of course, my friend and dear colleague, Dr. Sharad Kumar, who is the most popular neuroradiologist in town. So without wasting further time, I would like to welcome all the panelists. I would like to welcome Dr. Guru Prasad. I would like to welcome Dr. Raghunandan Nadik, and also Dr. Uma Shankar. And thank you, entire BNET team, including Dr. Rajesh K and Dr. Prashant and everyone, you know, who giving this opportunity and making this an academic feast. Thank you once again. And I would like to invite Mr. Ganeshan C, who is the Vice President, Synapse Micro Division, to just start the proceedings. Welcome, sir.
At the outset, I should thank BNET once again for giving us an opportunity to be a part of what Dr. Amit Kulkarni said, the feast, the scientific feast. I think amongst, I mean, like so many webinars that I see, one of the best attended webinars series is the BNET series, and full marks to the entire BNET team for having made this a very successful series. I wish them every luck, and then also to continue this scientific program, and also at the same time promise to be a part of it always and anytime it demands. So thanks a lot. I once again welcome the panelists and also the participants over to the scientific program. Thank you.
Thank you, sir. Now I would welcome Dr. L. Krishnamurthy, sir, to take over the dais and to introduce the first speaker for today.
Thank you. Thank you. Namaste. Good evening. Thank you, Amit, for the nice introduction. Thank you, Mr. Ganeshan. We have today a case presentation and four discussions along with a debate. We know that we have just come out of the World Stroke Day, and today we are taking up a venous stroke as a part of the World Stroke Day. At the outset, I thank BNET team for inviting me to be the chair of this day. And as we all know, CVT is an important cause of stroke in young adults, especially around 33 plus years of age. And it accounts for about 0.5 to 1% of all the unselected strokes in the world. And it is 3 times more common in women. Without taking much of your time, I request Mayank to go ahead with this case presentation. Dr. Mayank?
Sure, sir. So good evening to all the guests and respected faculty is present out here. So today my case was it's not moving ahead.
Just click on the screen once.
So I have to click it again and again.
No, not necessarily.
Okay. So this was a 45-year-old female, mother of 2, and she was Ayurvedic physician. Was non-hypertensive, non-diabetic, not having any premorbid illness in the past, and was not on any medication. And she presented to us with 2 days history of headache, which was holocranial throbbing associated with nausea and multiple episodes of the vomiting, mainly on lying down, and 1 day history of the left-sided weakness of both upper and the lower limbs, along with the blurring of the visions with floaters. So on asking about the family history, she had multiple members in the family, including one brother and the father who had a history of venous thrombosis in the past. So her examination, she was afebrile and the BP was normal. She was conscious but confused, a little bit irritable, and speech was slurred, and the left-sided hemiparesis was present. So considering her clinical signs, symptoms, and the history, we thought of taking up the imaging, which showed in the CT, the sagittal sinus along with the right transverse and the going towards the sigmoid sinus, thrombosis was present. The hyperintense sinuses was there on the CT, and this finding was corroborated in the MRI, which was showing the flow wide in the T2 in MRI of the superior sagittal sinus. And here we can see right transverse going till the sigmoid sinus. An MRV was done, which was showing the posterior part of the superior sagittal sinus was not visible at all, so as the right transverse and the sigmoid sinus. So she had been started on treatment, started on anticoagulant, systemic anticoagulant, anti-edema measurements, and the other supportive treatments. She was doing well till 1 day, but next day she started deteriorating clinically in the form that her left-sided weakness, it increased, and also started having new onset right-sided weakness. So her anti-edema and the anticoagulation was optimized, but still she continues to worsen. So thought of repeating the CT, and the repeat CT was showing the developing venous infarct on the right high frontal. You can see here the hyperintensity was developing and the edema was also increasing. So considering the clinical and the radiological progression, the question was what next? So this question is not for answering, just for having an outlook from other physicians and the treating neurologists, that should we wait and watch or we should go for invasive treatment? I think the options are not kept like this, so I would move ahead, and we opted for thrombolysis. So we opted for in situ thrombolysis, and by using injection altiplase, the 2 milligram bolus followed by 1 milligram per hour continuous infusion was given by the microcatheter that was placed at the site of the superior sagittal sinus thrombosis. So this you can see, microcatheter is there, and the anterior part of the superior sagittal sinus was visible, whereas we are not able to see the posterior part. So after thrombolysis, so this was the angio finding. So now we can see the posterior part of the superior sagittal sinus, which is partially recanalized. So this is the picture of the same, showing the anterior part of the superior sagittal, which is visible with reflex on the deep cortical veins. And this is the picture after thrombolysis, which is showing that the posterior part is now visible. It is partially recanalized. So clinically, patient started showing recovery within 12 hours after stopping the infusion. Her right-sided weakness resolved completely, and she became more alert. Extubated within next 24 hours. Her left-sided weakness also started recovering, and gradually within next 2 to 3 days, she started ambulating without support. Her blood investigations were sent, which was showing the elevated IgM antiphospholipid antibodies with normal IgG level, and the screening test for LA through Russell Viper venom test was positive. Her serum homocysteine vitamin B12 was normal, and hemogram was also normal, while the other routine investigation, including KFT and the lipid profiles, were normal. So the conclusion is that the timely surgical intervention can one of the good option in the patient who doesn't respond to maximum dose of conservative management, including anticoagulants and the anti-edema, though not used very often in the clinical practice. So that's why we thought of presenting this case. Thank you.
Thank you, Dr. Mayank. It's an excellent presentation. You go ahead subsequently after the thrombolysis, and on a long-term basis, what do you do?
So we had started with oral anticoagulant, and we put her on warfarin because few studies showed that putting her on the like vitamin K antagonist is a better option when she is having these tests positive. Though we thought of repeating the same test once again after a few weeks, and along with that, we had overlapped with the, if it had been some other sort of CVT without any provoking factor, we could have opted for NOACs also. But in this case, we opted for a long-term anticoagulation with the vitamin K antagonist.
She had positivity
just
of
adding
APLA antibodies.
Yeah, just adding to what Mayank said, he's mentioned about strong family history. Both her parents had venous thrombotic events, and brother and one of the sisters had thrombotic events. We were surprised at why she was not tested. Two of them were factor V Leiden positive, and two were protein C deficient. So strong family of congenital thrombophilia in the family. So we were suspecting her to be having protein C deficiency. So the initial thought was to add NOAC, because NOAC is okay to be effective in protein C deficiency. But when we got the report of APLA being positive, so our hematologist mentioned that vitamin K antagonist probably will be effective for both. So we started on warfarin, overlapping with initial Clexane and then nothing. So as he mentioned, she was obese lady. She was on 80 BD of low molecular heparin. Despite that, she progressed, and we had to take her up for in-situ thrombolysis in the middle of the night. I mean, this is probably the first time I've had this experience. We had lost some of the patients with venous thrombosis, massive venous infarct and significant amount of cerebral edema, and they succumbed despite being on maximum amount of anti-edema measures. But this the lady, not much of venous infarct, but the thrombus was extending. She was deteriorating clinically. I thought this was the ideal situation where you can look at intervention, and it worked magic. So I think it's a great eye opener for me, at least in my practice, where I think we need to use this tool much more frequently than allow them to worsen in front of our eyes.
Just one question: how long was the patient on anticoagulation before this this decision was taken?
36 hours.
Okay, that's good enough time for the anticoagulants to work.
Correct,
And
correct.
In CVT, the most worsening happens due to cerebral edema. So venous clogging. So if there is a large vessel occlusion like a superior vegetal sinus thrombosis, we have also seen in 24 hours also, you see that patient is deteriorating, sensorium not improving. Like we can take them up for thrombectomy. We have done even on admission only. We did a patient because it was an extensively thrombosis patient. And see, the good thing is next 24 hours he could be extubated and he has fully become normal, which will not happen. You try anticoagulant, see for 48 hours worsening. I think there is some criteria now worsening. Some venous scores are there. If large vessel more than 2 veins occluded, cerebral edema one kind. I think Dr. Sharath may be speaking on that. I think we should keep our open for a thrombectomy. Not that every patient, but definitely superior sagittal sinus, transverse sinus, both are thrombus and worsening in front of us, becoming drowsy. Edema is more, then one should consider thrombectomy.
so
And
this
as Guru
patient,
mentioned, see, we have this APLA patients because we had one patient who was DVT, who was on warfarin. So the doctors changed for NOAC. So actually he came with CVT on a good NOAC. So then he had a APLA syndrome. So whenever there is an APLA, it is always better to start warfarin. NOACs, there is no evidence as of now. So that is one thing means we have learned from the experience. And our immunologists also say NOACs, it doesn't work in APLA syndrome.
But in this patient, we mostly we feel that she'll be also having protein C deficiency. But we all know that we usually don't check for protein C, proteinase during acute thrombosis. We usually do that after 6 months after anticoagulation. So the plan is to do all this workup, thrombophilia workup after 6 months, stopping the oral anticoagulation, putting them on heparin, and then checking all these things. Repeat again, apply and all. If it is deficient and microglobulin improves, then stop warfarin, put them on NOAC. Because practically that will be much more easier to manage. Being an Ayurvedic physician, busy practitioner, follow-up will be very easy for herself also. We'll see. We'll give the options to the patient and then decide.
He has to be on probably lifetime anticoagulation.
Correct.
There are two problems here. One is APLA antibody positivity and C deficiency. Both of them come under the category of severe thrombophilia.
Correct.
So this lady needs to be on, mostly if it's proven further after 6 months, she needs to be on lifetime anticoagulation.
Yeah.
Nice case. Mayank, very nice case. Thank you.
Thank you, sir.
We'll now move on to the next talk. The next speaker will be Dr. Harish H. He's from my neighbor. Shimoga. He is a consultant neurologist at Sahyadri Narayana Multi-Speciality Hospital at Shimoga. How much to investigate the case of cerebral venous thrombosis? Please take over. Harish?
Hello.
Dr. Harish? You can take over, please.
Am I audible?
You are audible.
Hello? Yeah. Good evening, everyone. At the outset, I thank BNET for asking me to give lecture on this topic. It's actually not a pure neurological issue, that is evaluation. The topic is CVT and other venous thromboembolism, how we approach in terms of managing, in evaluating, in investigating this patient. First of all, in contrast to arterial strokes, what we see, generally physician and neurologists are the ones who deal with most of the arterial events. But when it comes to venous thromboembolism, it is general, including general practitioner, obstetrician, surgeons, orthopedicians, neurosurgeons, oncologists. So it's a wide spectrum where each one of us should know some basic principles in evaluating these patients. First of all, coming to venous thromboembolism, we all know this concept of Virchow's triad, which the picture, the person in the picture is Rudolf Virchow. He's a German physician. He didn't mention about this triad. What he found was in the pulmonary embolism patients, happened in the 1850s, where pulmonary embolism patient, he attributed them to be having secondary to venous stasis, number one, and some inherited or hypercoagulal state, hyperviscosity. He didn't mention about endothelial injury. Almost a century later, in 1950s, this concept of virchostriad came into. And why this is important? Because when we evaluate these patients, our focus is mainly on hypercoagulability state. We can't do any investigation for vessel wall injury, endothelial injury, or venous stasis. Our main aim is to look for any acquired or inherited hypercoagulous state which is underlying. Next slide, please. Before we discuss the what all investigation we do, first it's very important to know the basics of coagulation cascade. Whenever there is an endothelial injury, the factor 7 gets activated, that is extrinsic pathway, followed by the other factors. The rest all comes in intrinsic pathway. So this is very important to know, because when coagulation process starts, there is natural natural ability of body to stop excess coagulation is by anticoagulants, which we'll discuss in coming slides. Next slide, please. This D-dimer is very important. Why? Because the D-dimer, especially in DVT patients, if you look, it has what is called a negative predictive value. You can just rule out if you are suspecting a case to be in deep vein thrombosis and patient's D-dimer is normal. If it is high, it will not say patient has got DVT. But if it's normal, then it essentially rules out possibility of a DVT case. It's more so in our neurological CVT cases also, where recently a paper published which suggested including D-dimer values in evaluating a patient who is clinically suspicious of CVT can improve your ability to diagnose them as CVT before we do an imaging. So basically, this is a 4-step process where if you look at DED, it's a fibrinogen, it's a trinodular structure. Once coagulation process starts in, that is once thrombin is activated, it makes sure the DED molecule gets laterally assembled. That is the action of thrombin, that is called as fibrin assembly, followed by factor 13A helps in what is called as cross-linking. The DED, the bond between two trinodular structures becomes evident with 13A. But as I told, the body's response of plasmin, which is a zymogen, when it gets activated, when there is a coagulation process sets in, it lyses at these bonds and relieves two D contents, that is D-dimer. This is indicative of inherent thrombolysis. It may be ineffective, but the D-dimer value, which is quantitatively once assessed, will help in prognosticating some cases and more so in ruling out possibility of venous thromboembolism. Next slide, please. So basically, whenever we come across any VTE, whether it may be a mesenteric, cerebral, that is CVT, or DVT or pulmonary embolism, most of the tests what we do is basic complete blood count, coagulation tests like PT, APTT, D-dimer as I explained, homocysteine, very important, LFT, RFT, because some coagulation factors which are vitamin K dependent can be reduced in acquired liver dysfunction, and even some drugs can do that. And inherited thrombophilia test, as case discussed by Dr. Mayank, had patient with significant familial history. We need to do these tests. And most common acquired thrombophilic state is APLA antibodies. So we go one by one. Next slide, please. So coming to first, whenever we see patient with any venous thromboembolism, first we look at hemoglobin. Normally the range is 17 grams for males and 15 grams for females. If in case hemoglobin is in excess of 20 gram%, or packed cell volume is more than, hematocrit is more than 60%, this should make us think about hyperviscosity secondary to erythrocytosis. So polycythemia by definition is more common in erythrocytosis. All three cell lineages, if they are increased, it says polycythemia. How to go about when we see hemoglobin? First, we generally ask whether a patient is a smoker, because smokers erythrocyte can do that. Three important, though the slide looks very complex, the basic idea is to know only three things. One is what is the hemoglobin level. Second, patient's absolute RBC mass, because to rule out spurious erythrocytosis, because secondary to and pelvis. No, back.
Dr. Harish, your audio is not coming.
Because the management entirely differs in these patients. This is not just about targeting excess RBC content in the blood, but also the management differs because anticoagulation will not work. The thing is, we need to reduce RBC with other drugs. Next slide, please. Coming to homocysteine, this was well known since 1969 when Macaulay he published a patient with hyperhomocystinemia in a young patient who died because of vascular events, the coronary event. This patient had homocystinuria. So there is no doubt that in a patient with arterial event or venous, there is excess of homocysteine. Homocysteine is nothing but an amino acid. It is an intermediate amino acid which is once methionine is which is an essential amino acid. When it gets demethylated, we get homocysteine. Next slide, please. So it's very important to know this pathway. We know this diagram in our most of our neurology lectures related to subacute combined degeneration, where we think of B12 deficiency. But here, what I would like to emphasize is there are three pathways. First, in the homocysteine is synthesized from methionine. After, as we know, by donating methyl, it acts as a methyl donor. By doing that, homocysteine is generated. Homocysteine is sometimes it is atherogenic inflammatory molecule. So the one way to reduce homocysteine, it has to go back to its original, that is methionine, by remethylation. To remethylation to happen, there are two enzymes and three cofactors. If you look at MTHFR, that is methylene tetrahydrofolate reductase gene, is the one which is folate dependent, and methionine synthase, which is B12 dependent. And if you look at what the other fate of homocysteine is, it can go and become cystathionine with the help of cystathionine beta synthase. So whenever genetic cause for hypohomocysteine is suspected, only three enzymes can do that. One is CBS, that is cystathionine beta synthase enzyme deficiency, methionine synthase related problem, or MTHFR. MTHFR is not very convincingly proven to be associated with hyperhomocysteine simply because it has homozygous state is almost present in general population 10 to 15%, and heterozygosity of up to 30 to 40%. So its role as a pathogenic marker in hyperhomocysteine is not very proven. Next slide, please. So this is the same thing, which is simply elaborating. The cystathionine pathway is a trans-sulfuration pathway which occurs at liver cells. The rest occurs at other body cells. So these three enzymes can do that, or simply deficiency of folate or B12 or B6. These three vitamins deficiency can cause hyperhomocystinemia, which is which can cause hypercoagulatory state. Next slide, please. So we all know that homocysteine can cause is a pathogenic molecule in causing thromboembolic episodes. But if you ask any cardiologist, they generally deny that. But we in neurology practice, we generally say it is by reducing homocysteine, we can prevent recurrence of venous thromboembolism. And even large study in Chinese population, about 20,000 patients, where hypertensive patient, where by supplementing with B6, B9, and B12, they found there is a decreased incidence of stroke in them. So homocysteine, it has got a complex role. Why in cardiac, that is coronary patient, it is not very convincingly reduced mortality is simply because if you look at the left hand side at the upper border, folate not only helps in converting homocysteine to methionine, it also has got some role in thymidine pathway, which is a DNA related pathway, where they have found in stented patient, coronary artery stented patient, by simply supplementing them with all these three vitamins, sometimes it can cause cell proliferation and thereby reocclusion of those stents. So in them, that's the reason that why this was negative. But in related to stroke and venous thromboembolism, it is found to be helpful in reducing homocysteine levels. Next slide, please. So coming to we have discussed about excess RBC mass, that is polycythemia, and even I forgot to mention even anemia can be a hypercoagulous state in itself. Second, we discussed about homocysteine. Third, Apla syndrome, which is an acquired thrombotic state. The incidence, if you ask, the incidence is almost 2 to 5% in general population. It is not that it's very uncommon, it is common, but the person, this entity came into picture in 1983 when Graham Hughes, the person in the right hand corner, he was the one first to describe this entity as Apla. The clinical manifestations of Apla is so varied. It can simply come as a DVT. It can cause recurrent fetal loss in women, leading to pregnancy loss, or it can cause catastrophic event where it can cause multiple organ involvement and the patient can die. So it's a varied, and what determines is the diagnosis of Apla syndrome depends on clinical lab related criteria, where clinically at least one venous or an arterial event in any organ. Second, pregnancy related complications, either one of these are, and the laboratory criteria is there are 3 antibodies which are implicated in Apla antibodies, that is lupus anticoagulant, IgG, IgM anticardiolipin antibodies, or IgG, IgM anti-beta glycoprotein 1 antibody. Any one of these. The problem is the technique with what the lab people are doing, because it is mentioned in SOPRO criteria, where this is actually a research criteria, but still we use it as a clinical in clinical practice also. The titer should be more than 40 units or more than 99 percentile, which is an ELISA based method, and the 2 in vitro clot based assays should be done. The thing, as Dr. Earlier case we discussed, where one presence of a antibody at one point in time will not establish the diagnosis, simply because it is an acute phase reactant like antibody, where it can wax and wane. So we need to establish that it is persistent, and we need to test this antibody at the end of 3 months. So you need to check twice, 3 months apart, and antibody should be there. The incidence, as I told, prevalence is 2 to 5%, but there are some conditions where the incidence is more. Like in rheumatologic condition like SLE, this can be present in up to 1/3 of patients. 30 to 35% of SLE patient can have APLA antibodies. So APLA antibodies with one clinical event is suggestive of APLA. So when to suspect? They have mentioned like clinically, if you come across skin manifestation like livedo reticularis, reticular distribution skin changes, and one important blood parameter is someone comes with thrombocytopenia with prolonged APTT. We need to think about this APLA syndrome because it is a highly thrombotic state and patient is at risk for recurrent of events. Next slide, please. So coming to, as I mentioned, recently this study was published in Neurology, where they considered CVT patient. Generally, we say when someone comes with severe headache, like thunderclap and focal neurological deficit, we generally tend to consider this study also involved patients with duration of headache for more than 6 days. The woman who used OC pills, depending on these factors, they gave scores. And someone with known thrombophilia and seizures. In these 6 factors, with in addition of if D dimer is elevated, that gives more in favor of diagnosing CVT patients. So D dimer has a value in ruling in D dimer in CVT patients. Next slide, please. So first of all, before we do any test, the most important factor is whether it's a provoked event or unprovoked. Provoked, we all know, major surgery, orthopedic, neurosurgical, or immobile state, major acute illness, hyperestrogenic states like using OC pills or pregnancy is a factor in them. Next slide, please. Because a patient who had provoked event will generally have less than 1% risk of having a recurrence of venous thromboembolism, irrespective of his hypercoagulability status results. Even the coagulation profile, the thrombophilic state is positive. If it is a provoked event, the chances are very less that he's going to have one more recurrence of VTE. As against unprovoked, at the end of 2 years, the risk is 10%. At the end of 5 years, 40%. At the end of 10 years, 50%. So this is very high. So we need to examine these patients for hypercoagulable state. Next slide, please. So these 4 questions needs to be answered in subsequent slide. Next slide, please. When to suspect inherited thrombophilia? When VTE occurs in a young patient with strong family history, when the VTE happened recurrent twice or thrice, and unusual sites like what we see in CVT or in splanchnic, mesenteric or hepatic splenic vein thrombosis, we need to consider doing these tests. Next slide. Do not test when once we have diagnosed CVT or DVT, there is no need to test thrombophilic profile in them, simply because our treatment will not change. We all know that the acute thrombotic state will have a significant effect on levels of these factors. So one should not do a test in acute event. While someone is taking anticoagulation, especially heparin for 1 day will alter, warfarin for almost 2 weeks, and newer anticoagulants for almost 3 days, one should not do. Patient should be treatment free at least for 2 to 4 weeks before we ask for this type of test. And do not test in strong provoking factors. There is no, it will not change the management. Next slide, please.
Dr. Harish, requesting you to wind up faster.
Yeah. Okay. Protein C and protein S, as we know, it's a naturally occurring anticoagulant. The action is by inactivating factor 5 and factor 8. So next slide, please. Next slide. So presence of factor 5 lead-in, that is activated protein C resistance, it is age dependent. As the patient gets age advances and with some inciting events like OC pills or hormone replacement therapy, there is some threshold for having a event above which patient can have event. So simply presence of thrombophilic state will not call them for taking lifelong anticoagulation. It depends on what type of provoking factors has incited the event. Next slide. These are a test. The factor V Leiden and prothrombin are the gain of function. They are PCR related. The protein C, S, and antithrombin are level related, the functional activity related, and APLA we discussed. Next slide. This is same. This is a complex slide, but the simple answer is do not test the thrombophilic state when someone is on taking medications. Next slide. So results depends on the ethnicity, homozygous state, heterozygous state, and so many acquired like liver dysfunction, and drugs can alter the levels of these anticoagulants. And next slide, please. Next. And this is very important. Go back. Simple negative results in a strong family history will not make them patients at low risk. At the same time, positive results should not make them to take medication for over time, because it has got psychological effect also. Next slide. So next slide. Next. So the any provoking factors do not test. The unusual sites like CVT or mesenteric, one should test for these 5 anticoagulation, thrombophilic states. And someone coming with mesenteric, one should look for PNH, that is paroxysmal nocturnal hemoglobinuria, and myeloproliferative neoplasms. Next slide. This is simply, in a couple of minutes I will end. The role of thrombophilia will not determine recurrence, because few studies which I come across, like DASH score, this is D-dimer related. There is no way there is mention of positive thrombophilic state will lead to recurrence of events. Next slide. Similarly, this R2 rule also similar. Next slide. So choosing wisely is very important, simply because tests are easily available. We need to be very we should not use indiscriminately. We should know what clinical setting patient has developed this VTE, and then one should ask for investigation. Next slide. This is NICE guidelines. There are no guidelines to test. These are basically, there is no evidence based. These are expert opinion related. Next slide. Next. To conclude, this is the article I came across in NEJM. The opening remark, what they mention is asking for an hypercoagulability status is very easy, but interpreting its results and in what way it is going to change patient's management is very complex. So we need to be very, very cautious in asking. And there are few conditions where it has to be done. And there are some conditions like unprovoked, strong provoking factors, one need not do these thrombophilic states. Next slide. So to conclude, this is a multifactorial process. We need to choose patients very in correct manner, because the test what we do has got some limitations. And whenever you are in doubt regarding interpreting results, you should consult your hematologist. Next slide. Thank you. Thank you. Sorry, I have overrun time. Sorry.
Thank you, Dr. Harish, for a wonderful presentation. I think he stressed upon very important factors of provoked DVTs, provoked VTEs, and non-provoked VTEs, and not to consider empirical long-term anticoagulation in all patients. And also he very nicely emphasized upon the lab factors involved in these kind of testings. He did full justice to his talk. Probably he deserved a little more time. Thank you once again. I think
thank you.
We can, Krishnamurthy sir, I think you can proceed with the next speaker. Is sir there?
Yeah, I'm here. Can you hear me? Can you hear me?
Yes, sir.
We'll go on. The next topic will be by Dr. Dayanand. who is a neurologist at Fortis Hospital, Bangalore. How long to treat in the case of CVT? Please take over, sir.
Okay, thank you. Few seconds. I'll be opening the presentation. Okay. Can you see the slides, all of you?
Yes, we can see.
Okay. So my topic is made simple by previous speakers, how to test and how long to, what are the criteria to test. So my topic is how long to treat. So I'll be briefing on short-term management and also long-term management. What I will not be speaking about is NOVAX, where fine. So NOVAX, which will be discussed in the next session. And so I stick to current recommendations, which where long-term medications are usually recommended is vitamin K antagonist. So to understand, I'll also speak about some recanalization and its effects on the prognosis, and also recurrent DVTs or recurrent CVTs. What is the rate and what is the current status? I'll also touch upon some interesting points in like pregnancy in CVT and pediatric CVT, a brief about that. After that, we'll discuss about some of the index cases, clinical cases, so as to see how we can formulate the long-term prognosis, long-term management. So CVT, as we know, is a potentially life-threatening stroke, and it has to be managed in ICU, and especially in the stroke care, to get the best results. So initial therapy, all of us knows it is injectable anticoagulant. So what does the initial therapy achieve? It achieves to prevent the further extension of the thrombosis and life-threatening complications. So long-term therapies, it carries forward the whatever benefit which is achieved in the acute therapy, and also it is aimed at the prevention of the late complications. So to know how long to treat and how to treat, we should know the etiology, pathology, and complications of the disease. This is a list of this is all the list of CVT causative agent. So right from the prothrombotic conditions, infections, mechanical trauma, intracranial defects, we divide this into the provoked and the unprovoked status. So provoked is there is a causative agent which incites the onset of the thrombus. Unprovoked is in a history wise and also in examination, we don't find any other clue regarding the causative agent for for CVT. So provoked is right from the infection to the systemic sepsis, COVID, and oral contraceptives is quite common. Pregnancy, puerperium, dehydration. There's so many causes are there. Unprovoked is usually majority of the times it is undiagnosed. So few of them we treat it as a causative agent, thrombophilia. So it can be acquired or hereditary. There are some systemic malignancies, disease malignancies, vasculitis syndromes, can also present as unprovoked CVTs. So pathogenesis, we all know. So there is a increased pressure due to the blockage of the veins, raised ICP, disruption of the blood-brain barrier, and parenchymal hemorrhage, which leads to infarction. It can cause a life-threatening condition. So the complications are a persistent headache, so complications of raised ICP, so visual complication, cerebral herniation. Another one complication is seizures, which can be present even without focal lesions. There can be parenchymal hemorrhage, which can cause various neurological deficits. There can be development of hydrocephalus, which can be communicative or non-communicative. So CVT, the complication and prognosis depend on the rate of the which the disease is onset, and also it also depends on the available collaterals. And also depends on the associated illness like internal malignancy, pregnancy, vasculitis syndromes, severe thrombophobia. So seizure, and especially in the status epilepticus, also depends also a very important factor which determines the prognosis. So, and finally, the effective management in the best stroke care unit is important. So we all know what are the modalities of the management: short-term management and long-term management of anticoagulations. Fibrinolysis already been one case has been presented, and further there will be a talk on fibrinolysis. So these are all the complications we have. So initial anticoagulation. So what has been recommended is heparin or low molecular weight heparin, unfractionated heparin or low molecular weight heparin, and long term is a vitamin K antagonist and Novax. So Novax will come probably in the next recommendation. There are so many data are piling in, and people are already prescribing it. So this is one blood clotting. These are all various anticoagulants which are used for the chronic and acute management. So here we have Novax, there is a dabigatran, and these are all rivaroxaban and dexaban and all are acting on the 10th. Warfarin generally acts on multiple coagulative parameter because of which causes a deficiency of vitamin K. So this is a combined fibrinolysis and clot. So he see the protein S and protein C inhibits thrombosis, antithrombin inhibits thrombosis, and the plasmin helpful for the degradation of the clot. What's the role of heparin? It's already way back in 90s and 80s. It's already proved that in the randomized trials that both are effective. Unfractionated heparin and the low molecular weight heparin is both are effective, followed by the vitamin K antagonist. So longest study is ISVT, which was appeared in stroke in 2004. So where in 21 countries participated, 624 patients followed up for 16 months. So there is a majority of people had a good prognosis, around 80%. Mortalities were around 8%. 2.2% was severely disabled. So one important thing is which was observed is there are 2.2% of patient had recurrent CVT, and 4%, around 4% had VT episodes. Now, what you ask, does the recanalization improve the regional perfusion? So it's not so always, because it all depends on so many things. One is collateralization. Venous circulation has got a robust collaterals, and if there is a blockage of the microcirculation, so in spite of recanalization, there may not be good achievement of the result. So if it is a late recanalization, so again the objective may not be sufficient. So the same thing in assessing the recanalization and the prognosis. So there are many studies which has proven that the recanalization is independent predictor for the prognosis. So this is a study, is meta-analysis, 19 studies which appeared in a stroke 2018. The overall recanalization was 85%, and of which 49 were complete and 35 were in partial. At 3 months, 33% were recanalized, 80% at 9 months. This says that more we prolong the treatment, the more we achieve the recanalization. There are some predictive factors for recanalization. Single CVT, pregnancy preparing younger age, they're more likely to recanalize than other old age, deep venous system involvement, and unprovoked CVT. So, what is the recurrence rate? ISCVT international study shows 2.2% had a recurrent CVT and 4.3% had a recurrent other venous thromboembolism episodes. So the follow is another another study which followed up 145 patients who were referred for thrombophysiological workup, also showed the similar results. Some insight into the thrombophilias. They can be hereditary or acquired. So mild thrombophilias are heterozygous. Homozygous varieties are very severe one. So we can see the VTE recurrence as much as 55% in and around 10 years, those who have these thrombophilias. So hyperhomocystinemia is not significantly associated with the recurrence of the CVT. So when to test is already been shown, already been discussed in the previous. Usually through 2 to 4 weeks after stopping anticoagulation, antiphospholipid syndrome should be on 2 occasions it should be proved. So seizures with symptoms symptomatic or asymptomatic. So in ISCVT, 11% of the patients had seizures, and 66 out of 624 had seizures at the end of the 2 years. In summary, testing for anticoagulant state is indicated in unprovoked CVT, and in the patients with provoked CVT, anticoagulation should be 3 to 6 months, and unprovoked CVT, it should be 6 months to 12 months. Recurrent CVT or VTE or severe thrombophilia, there is an indefinite anticoagulation, and follow-up imaging is indicated in 3 to 6 months or in future just before the discontinuation of anticoagulation. So CVT in pregnancy and purpurum, pregnancy is hypercoagulable state, and prevalence varies within different countries. First trimester and 4 weeks after postpartum is very highly thrombogenic, and iron deficiency anemia, postpartum hemorrhage, eclampsia. So these are the precipitating factors. Unfractionated heparin and warfarin is teratogenic. Low molecular weight heparin is indicated. So these are some studies of longest studies which showed there is a 12 recurrences in and 24 non-VT in 1,000 per 1,000 pregnancies. Miscarriage was not evident from these two, those with prophylaxis and not with prophylaxis. So the same thing with the other studies. So recommendation is so low molecular weight throughout pregnancy, followed by postpartum vitamin K antagonist for at least 6 months. Future pregnancy is not contraindicated. Those who have a hypercoagulable state, they require future lifelong treatment. So we discuss case 1. So this is one of the two cases I'll discuss. So 35-year-old man who works in the cement industry, presented with new onset of headache, blurred vision, 1 week, on examination diplopia, general examination muddy eyes, pulmonary erythema, smoker for 10 days. He had a bout of vomiting after drinks. So hemoglobin was high, PCB highs, rest was normal. He threw a seizure. So imaging shows hemorrhagic infarction with mild mass effect. So MRV shows supracervical thrombosis. This is a provoked CVT provoked by dehydration polycythemia. So usual anti-edema measures, low heparin. How long it should be treated? 3 to 6 months. Ensure polycythemia should be treated. How long the anti-epileptic should be given? It should be at least 1 to 2 years. probably long-term if he develops a long-term complications. This is a patient, 26-year-old female, 7 months pregnant, develops a headache for hemiparesis. She has 2 miscarriages. She has a evidence of 3 months DVT. MRI shows supracerebral thrombosis. So the unprovoked CVT, young age, she has a history suggestive of Aplas syndrome, lifelong anticoagulant, workup thrombophilia is important, indefinite anticoagulation. Case 3, another one, 38-year-old male presented with mild headache, blurred vision, 3 weeks, no remarkable history, routine workup normal, MRV is extensive thrombosis, and it is a subacute and chronic unprovoked CVT. Plan anticoagulation for 12 months, and the thrombophilia work later. D-dimer estimation in between if there is a continuous headache. Recanalization is complete in this, and he needs a close follow-up in spite of the recanalization, and thrombophilia workup is negative. This is one of the case on my friend's relative. Chest shows ground glass appearance. This is extensive CVT. This is a unprovoked CVT. This is a COVID positive CVT. So pediatric cases, in neonates, some people tries to wait and watch before 28 days. Beyond 28 days, it will be treated as adults like adults. So thrombophilia workup is necessary. So headache is a common. 29% will have a tension type of headache, and visual loss is important, which it has to be prevented, and repeated CSF drainage surgical, it can is a surgical option is another thing. So dural fissuras are common. It usually closes. Uncommon, it usually closes by itself upon recanalization. In conclusion, CVT is a potential life-threatening condition which needs both acute and chronic management, and there is a good prognosis in majority of the patients. The duration of anticoagulant therapy depends on cause. In provoked CVT, 3 to 6 months, unprovoked CVT, 6 months to 12 months, and the presence of hereditary thrombophilia or procoagulant state, systemic vasculitis, there is an indefinite indication. AEDs for seizures is reasonable for a reasonable period, guided by focal lesions. So probably 6 months to 2 years or more if they develop the scar epilepsy. The late complications like raised ICT, papilledema, and the usual visual loss to be addressed accordingly in the future. Thank you.
Thank you, sir, for an excellent deliberation. I think you covered it very well as to how long to treat the CVT. I think since we have been, overshooting time, I would request Krishnamurthy sir to proceed with the next talk. I think we can take the questions at some time later. We can proceed with the next talk, and I request the speakers to stick to their timings, please.
Also request the speakers, if they have any related questions on the Q&A section, you can keep on answering them.
Yeah,
and some questions we'll be taking live also.
In the next will be a debate. Debate is regarding use of NOx or not. The talk will be by, for NOx will be by Dr. Sharavanan, and for against NOx will be by Dr. Nikhil Hidemat. Dr. Sharavanan, can you please take over? Sharavanan is a
thank you, sir.
Neurologist in Sagar Hospital, Bangalore.
Yeah.
Please take on your time.
Yes, sir.
Can we have the timer, please, for the debate?
Hi, everybody. Thank you, sir, for the introduction. I'll be talking about this. Can NOACs be the way forward in CVT? And I'll be talking for it. Before I start my talk, I just want to have a small poll where I want everyone to answer. How many of you have used this non-vitamin K oral anticoagulants in the management of CVT either recently or in the recent past or planning to use it. So kindly let me know. I'll just wait for 20 seconds for the results so that we can take a call on that further.
Taran, I hope that you don't jump onto the other side looking at the poll answer.
No, sir, definitely not. I think my answer, based on the answers, my job will be easier, I guess. Oh, that's good. I mean, like 47% of the 47% of you have used NOACs and 54% have not used. So in 140, maybe around, I have to just convince 10 to 15 people more to start using so that there is a majority of people using this. Thank you. Yeah, I'll be going through the current guidelines in short, the RESPECT CVT trial, ongoing trials about NOACs, and benefits of using NOACs, and finally concluding. It will be a very short talk. The initial guidelines came from AHA, ASA in 2001. So it's a very archaic guideline. So in them, we still follow them though. For patients, the first questions they asked was whether in patients with CVT anticoagulation is required or not required. So for them, it was definitely anticoagulation was required, followed by vitamin K anticoagulation. In the level class of it was class 2A recommendation with level B evidence. The second question they asked was how long to continue this thing. So in patients with provoked CVT, it was to be continued for 3 to 6 months with a target INR of 2 to 3. This was a class 2B with a level of evidence C. So definitely the evidence was low, and even at that time when recommending it. And the class of evidence, it is maybe, that is class 2B is maybe used again. So in unprovoked CVT, the same thing, it has to be used for 6 to 12 months. Again, it was a class 2B evidence with a level of evidence C. So both the level of evidence was very low kind of a thing for recommendation for them. At that time, what about the NOACs? There was no mention at that time because they were still new in the market. Dabigatran was released in 2010, so it was still an infant. Rivaroxaban was released in 2011, so it was a newborn looking at it. So with the lack of data at the time for NOACs in CVT, there was no mention of this in those guidelines. Next, we have the EAN guidelines, which came in 2017. Though they are fairly recent, they do mention about the DOACs. The first question they asked was, in patients with acute CVT, does anticoagulation improve clinical outcome compared to no anticoagulation? The answer was yes, definitely heparin is useful. The quality of evidence was moderate and the strength of recommendation was strong. So we all follow the same thing. The second question is duration of anticoagulation. The question they asked was whether a long-term anticoagulation versus short-term anticoagulation, more than 6 months, whether less than 6 months, which is useful. And the second question they asked was, for patients with recurrent previous CVT, does long-term anticoagulation reduce recurrent venous thrombotic events compared to treatment with short-term anticoagulation? So again, they suggested for a variable period. So there was no fixed timing as previously. It was a variable period varying from 3 to 12 months after CVT to prevent recurrence of CVT and venous thrombotic events. So it is only for these two indications. It was to be continued for 3 to 12 months. The quality of evidence was again very low and the strength of recommendation was weak. What about the NOACs? They did take this thing in patients with CVT. Does treatment with direct oral anticoagulants improve clinical outcome, reduce major hemorrhagic complications, and reduce thrombotic recurrence compared to conventional anticoagulation, that is vitamin K? At that time, they did not recommend the use of direct oral anticoagulation for CVT, especially during the acute phase only. But the long-term phase, there was no mention. Even for this recommendation, the quality of evidence was very low and the strength of recommendation was weak. So these recommendations are based on primarily two studies. The first study which came up was about case series of 7 patients treated with rivaroxaban, which was published in 2014, which showed that there were similar clinical benefits as vitamin K antagonist. Second study was a 15 case series, which is again a case series about dabigatran, published in 2015, in which excellent clinical outcome was there in most of the patients, and there was not much difference with other studies. Even after these studies, they gave a negative recommendation because it was a very small study. So that was the reason. So now what we have is the RESPECT CVT trial, which came in 2019, which is study safety and efficacy of dabigatran Elexate versus dose-adjusted warfarin in patients with cerebral venous thrombosis. It was a randomized clinical trial. What it said was it compared efficacy and safety of dabigatran Elexate with warfarin in patients with CVT and dural sinus thrombosis. Dabigatran 150 mg BD versus dose-adjusted warfarin was given in symptomatic CVT. 120 patients with CVT from Western Europe, Eastern Europe, and India were included. So definitely it is important for us because even Indian patients were there in that. So it includes the Indian scenario. After receiving parenteral anticoagulation for 5 to 15 days after diagnosis, patients with CVT were randomized 1:1 arm for either 24 weeks of treatment. They were monitored for bleeding complications, VTE, recanalization, and MRS scores. What this study concluded was both dabigatran and warfarin had low risk of recurrent VTE, and the risk of bleeding was similar in both medications, suggesting that both dabigatran and warfarin may be safe and effective for preventing recurrent VTE in patients with CVT. What will be the level of evidence? Since it's an old this thing, the previous studies are all old, previous recommendations are old. Even if the new recommendation come, since this is a randomized clinical trial, which is an exploratory, prospective, randomized parallel group open trial, which is a probe design trial. So this should qualify for a level B evidence. So definitely the evidence is more in favor of NOACs in CVT. The current trials which are in progress there are two prospective trials, which is both with rivaroxaban and vitamin K antagonist. So first trial is secret trial, that is study of rivaroxaban for cerebral venous thrombosis. Secret trial identified with this thing, which the recruitment is ongoing, which is the Canadian trial. The second trial, which is registered, is again comparison of efficacy of rivaroxaban to coumarin in cerebral venous thrombosis. It is from Pakistan, but they are still not yet started recruitment. Why we should be going ahead with NOACs? Why not vitamin K? These are the well-known facts which I'm just putting out in points. They are more predictable pharmacokinetics, no complicated dose adjustments, while at the same time having similar efficacy to vitamin K antagonists, similar if not better rates of bleeding and mortality, convenience of use, minor drug and food interactions, wide therapeutic window, no need for laboratory monitoring, and more important, reversal agent, especially for dabigatran, if the other ones are in the pipeline, which will be shortly available. Thank you. I think this explains why we are more in favor of NOACs than old vitamin K antagonists.
Thank you, Shravan. Thank you.
Thank you.
The number of cases, I think, probably are less.
Yes, sir. So probably if the 47 people, everyone puts 2 or 3 cases, that itself will add on to 150 cases. Sir. So that can be a very big series itself.
I think you've done an excellent job. We'll go on to the use of DKS by Dr. Nikhil Hiramat, who is a consultant neurologist at Sparsh Hospitals, Bangalore. Nikhil, take over, please.
Thank you, sir. I thank BNET team for giving me the opportunity to talk in this platform. The debate which I was given, given as can NOACs be the way forward in CVT, I will be speaking for vitamin K antagonists. So I will just start with one case, Venous, which I recently happened to see one patient who was a 16-year-old female who had a menorrhagia for the last 1.5 years before presentation and was on OCPs. And she presented with typical symptoms of headache, vomiting, seizures, followed by altered sensorium. And she had a poor GCS, pupillary asymmetry. She needed emergency decompression, followed by heparin. She had a baseline hemoglobin of 6.4 because she had a hemorrhagia. And during the hospital stay, she had a minor bleeding PV. So she had an endometrial thickness of around 8 to 10 millimeters. And we had to give progesterone and GnRH analogs to, suppress the pituitary ovarian axis to, prevent the bleeding. So in this patient, I would just like to ask the panelists whether you want to use NOACs or warfarin. Let us see. So we know that there are a lot of many causes for CVT, and commonly we see what commonly we see in practice is acquired causes in the background of puerperium or OCP use, hormonal therapy, dehydration or something. And most of the trials or most of the observational studies which were reported earlier are involving these group of patients or causative factors. Once in a while, we do use commonly, we may or may not be common, but sometimes we might be missing these cases. So like hereditary factors, APLA, malignancies, and dural AV fistulas. So once in a while, we do see patients in these category. And as we know, the warfarin has been the standard therapy for almost decades now in CVT, in almost universally used in almost varying causes of CVT cases as well. So the advantage of warfarin being it is 100% available orally and has a maximum half-life compared to a newer oral anticoagulation, that is 40 hours, compared to newer anticoagulants which have a half-life of around 12 to 14 hours. And there is no renal clearance for warfarin. So the half-life is one thing, which is one advantage, is that even if you miss 1 or 2 doses of warfarin, so it may not change the INR much or the anticoagulation effect. But unlike in NOACs, where even if you miss 1 or 2 doses, the patient might have a thrombotic or a thromboembolic events. So as Sir told, the AHA guideline which came in 2011 mentioned the use of vitamin K antagonist, of course with the class 2A evidence. Subsequently, in 2017, in the European guidelines mentioned that they do not recommend using newer anticoagulation. Of course, the evidence was very low or weak, because it was almost like when the guidelines came in 2017, it was only the observational studies and not much of trials was seen. So then came the RESPECT CVT trial, which is till now the only trial which compares newer anticoagulation versus the vitamin K antagonist. Of course, there were other previous, as Sir mentioned about the observational studies, case series, which was a small number of patients were studied. This was the first trial which came in 2019 and which studied, which was a randomized control trial, which randomized patients with CVT into either a dabigatran arm or the warfarin arm with a standard anticoagulation dose. After initial acute phase of 5 to 15 days, the follow-up period was around 24 weeks. We don't have a follow-up more than 24 weeks according to the trial. And as per the trial, the exclusion criteria mainly was age less than 18 years and more than 80 years. Patient who had other central nervous system infections or head trauma were excluded, and patients after clinical stability only were included in the study. Patients who were planned for a surgical decompression were excluded. Patients who were planned for surgical intervention in the future were excluded. Prosthetic valves were excluded. Recent or current malignancy was excluded. Severe renal impairment was also excluded in the study. So when you see the enrollment details, patients finally, 120 patients were randomized into either 60 patients with dabigatran and 60 with warfarin. Among the patients who were randomized to dabigatran, 7 were excluded finally because one had a worsening of CVT, one had a major intestinal bleeding, and 5 others had other adverse events, which I'll be telling in the next slide. That is, 5 patients were adverse events were either epigastric or abdominal discomfort, urticaria, thrombocytopenia, and elevated liver enzymes. So among these 5 patients, 4 patients were finally changed over to vitamin K antagonist, that is warfarin, and 1 patient was changed over to low molecular weight heparin after discontinuing the trial. So we have few patients, that is 7 patients who were on dabigatran excluded because of some of the other risk factors. Only one or two patients in the warfarin group were discontinued in the study because of the bleeding. So when you see the baseline characteristics in the trial, that is RESPECT CVT, majority of the patients, the causative factors or the risk factors were either OCP use or obesity. So other factors, that is other risk factors, that is previous venous thromboembolism or recurrent thromboembolism or genetic thrombophilias or malignancies, were almost, the representation was very small. Previous thromboembolism was 10% of the patients, genetic thrombophilia was only 8% of the patients. Almost most of the patients were either obese or having oral contraceptive use as a risk factor. So, and puerperium as well was very small, 3 in dabigatran and 1 in warfarin group. So, and even the severity of the CVT patients who were enrolled in the trial, the CVT risk score among almost most of the patients, 80% or 80 to 85% of the patients were very mild CVT cases, and even the NIH score was around maybe 0 or 1 to 4. That was the majority of the patients were very mild per se. So we know that there are a lot of causes for CVT. We usually we find, or sometimes we miss thrombophilias initially when the patient comes, and there are many factors like APLA, malignancies, and all those things which are not usually studied in either previously in observational, or there are no randomized controlled trials. This was one of the study which came in 2016 in Lancet. That is a RAPS trial, which they studied the patients with antiphospholipid antibody syndrome, either randomized to rivaroxaban or warfarin. They concluded that the rivaroxaban did not reach the non-inferiority threshold in this trial. The next study, this is important, that is in 2018, they published a study called TRAPS, where they randomized patients of antiphospholipid syndrome into rivaroxaban arm and the warfarin arm with the target iron of 2.5. The trial was prematurely terminated because in the rivaroxaban arm, there were a lot of events, either the thromboembolic events or major bleeding or vascular death in patients. So they concluded that the use of rivaroxaban in high-risk patients with APLA was associated with increased risk of events compared to warfarin, thus showing no benefit. So the trial was prematurely terminated. So we commonly see patients in clinical practice who have APLA syndrome or which might have missed initially during the workup. So this was the chart which shows that there was a cumulative incidence of events in rivaroxaban group, either in the form of death or thromboembolic events or major bleeding. So regarding patients who have liver disease, what about the use of anticoagulation in patients who have liver disease? The FDA and the EMA, that is European Medical Agency, warfarin can be used in all classes of childbirth class, unlike in NOACs, where either we have to be cautious or cannot be used, depending on the stage of childbirth disease. So that is either B or C. Most of the in category childbirth B or C, most of the NOACs cannot be used or should be used with caution. So this was FDA and EMA recommendation. Finally, in patients who have renal disease, so we don't have much benefit compared to warfarin, except in most of the studies are in atrial fibrillation rather than in CVT. So atrial fibrillation studies like RELY and the Aristotle, they have studied that even in patients, the neuroanticoagulation can be used if there is GFR more than 30, but not less than 30. Though in patients who have less than 30, both warfarin as well as neuroanticoagulation, we have to use with caution. So with the GFR more than 30, of course, in AF patients who have a non-valvular AF, it has showed significant benefit, but we don't have data to say whether NOACs are better in CVT in these kind of patients. We don't have particular data on that. So this is the same slide which was repeated almost. So in patients with malignancy, so we don't have much evidence in malignancy also, but the latest guideline that is in NCCN, that is National Comprehensive Cancer Care Network in 2018, regarding the mention of anticoagulation for acute venous thromboembolism, that is a peripheral venous thromboembolism treatment, they say that low molecular weight heparin should be used for first 6 months in proximal DVT and pulmonary embolism. However, they also mentioned that edoxaban can be used only when the risk of bleeding in patients is less. So that is the caveat. So most of the patients they have used, tend to use low molecular weight heparin, but with the caveat that there is no much of a bleeding risk, edoxaban can be used. When there is a catheter-associated thrombosis, so they have mentioned anticoagulation for 3 months, but not mentioned regarding the newer anticoagulation. So, and subsequently, in Cochrane Library database that was published in 2017, what they say regarding use of newer anticoagulation versus warfarin, because of the low evidence, so they don't advise using newer anticoagulation. And however, the quality of evidence is very low according to the Cochrane database. So finally, what I will put it as, after initial evaluating the patient with cerebral venous sinus thrombosis, after initial anticoagulation with either low molecular weight heparin or unfractionated heparin, we need to basically see the risk score. So as per the details of RESPECT CVT, if there is a risk score is more, obviously I think we need to use vitamin K antagonist in preference rather than the newer anticoagulation. If the risk is less than 3 only, probably we might tend to use newer anticoagulation, because it is, as per the studies, most of them patients are having less CVT score or less NIHs. So only when the score is less than 3, probably we need to use newer anticoagulation. That's what I put it as. But most of the patients, universally speaking, in CVT patients, probably in Indian setup, where sometimes we do lose patients, or we may not be able to evaluate because of the financial reasons, probably universally we can use vitamin K antagonist compared to newer anticoagulation. So what the disadvantages of newer anticoagulation are, probably it is not advised in patients who are pregnancy or children less than 18 years, and not used in patients with mechanical heart valves or malignant disease. They are expensive, compliance can be a problem, non-availability of the antidotes in peripheries, limited experience with these drugs, and antidotes might be expensive or may not be available. So this is what I put it as. The CVT risk score, which the factors which are malignancy, coma, deep CVT, mental status disturbance, male sex, or intracranial hemorrhage, if the score is more than 3, obviously I think we will probably use, I would probably use warfarin or vitamin K antagonist. Only if the score is less than 3, probably I would think of using newer anticoagulation. But universally speaking, I think I will still go for warfarin or acetron in these patients. Thank you.
Thank you, Dr. Amit. It was an excellent talk. We are all purists. I am a purist. I have never used so far NOACs. One. Secondly, the problem is that they are expensive. I cannot use in my patients. They're expensive, definitely expensive. 3, as I see in your presentations, I do not see any benefit of using rivaroxaban or dabigatran over NOACs, over the routine warfarin or acetylcholine. I think in my experience, limited experience probably, I still stick on to the older anticoagulants, not the novel anticoagulants.
Sir, we'll give Dr. Saravanan a chance for a rebuttal, because the evidence is heavily stacked against him, and I think he deserves a fair rebuttal as to the use of NOACs. I think you should give a 2 or 3 point rebuttal regarding what Sir also said. I think a lot of people have that initial consideration of not using NOACs because firstly they're not very comfortable with it. I think what Sir said is right, especially the senior generation. But then I think when it comes to a long-term use of NOACs, I think this is something I think Dr. Saravanan would like to rebuttal.
Yes. So regarding the TRAPS trial, which is rivaroxaban versus this thing, so there are 2 or 3 points which has to be. So though the thrombotic, it was supposed to be include 500 plus patients to be included, but they stopped the trial at 120. The problem with that was, of these 120, only 9 of these patients had either CVT or DVT. They had other features of APLA. So it is purely an APLA based study and it is not for a CVT or DVT. So that is one thing. The second thing is all the events, whatever happened in rivaroxaban were of arterial in nature. There were no venous events even in those patients. So definitely in a purely venous or a low risk patient, definitely NOACs will definitely work. Whereas in a high risk patient, as this thing, warfarin remain the high risk patients. Second point is renal failure patients. Now there are evidence that edoxaban can be used in renal failure on hemodialysis. So definitely it's not a no-no. Even on hemodialysis, edoxaban can be used. The third point about liver dysfunction. Definitely liver dysfunction, most of us will not use anticoagulation because they already have a coagulation abnormality. So these are the 3 points I just wanted to say. So definitely the way forward, we have to sub-classify the CVT into a different groups, categories. So some category will go in for a NOACs and some category will go in for warfarin. So that needs a further study. Definitely I would go for that way. So probably a milder variant, we will definitely go in for a NOAC, and for a severe variant or any risk factors like APLA, we will go in for a warfarin. Thank you.
Thank you.
I think it was a wonderful session with a nice rebuttal also at the end. Dr. Nikhil, I think, has put his point of view very straightforward and clear when it comes to low NHSS or low score versus high score, and he's very clear in his thought process when he can use NOACs. And I think this should be for now. I think this should be what we should all follow until further evidence trickles in as far as the NOACs, the usage of NOACs is concerned. I agree with Krishnamurthy sir that definitely yes. I mean, as of now, we do not have so much of evidence. I also agree with what Dr. Nikhil has put it. Going forward, I think we need more data. But again, when there is a low risk and we're talking about long-term anticoagulation, we can still think about considering NOACs.
Why not the hybrid way? So initial for the full recanalization, after that long-term can be given NOACs.
That is what sometimes we are doing, sir. 3 months first warfarin, then switch over to NOAC and then follow up these patients. See, but that in respective issues also they have selected only there are exclusion. They were telling if more than 2 veins, if they have any significant deficit, they were excluded from the study. So it was a mild CVTs which were taken in because you are the part of the trial. So they were this one, even recurrent CVTs were avoided. And it has to be within 2 weeks. And then only the good thing about the trial, they allowed heparin therapy. Then you can decide on a switchover. So that was good thing, this one. So there was no bias of the treatment. So then the treatment aspect started based on the clinical decision of severity. So mild, I think definitely NOAC. So what we are going in between, we can give the offer to the patient. See, cost-wise also, if they come warfarin, check, PTINR, coming to the hospital, spending the time, the cost, it comes to about 2,000 versus 3,000 for the NOACs. That family will decide on that. We can give them an offer. There are both are available. They can choose. That's what we are doing many times. Sometimes they choose. Because
nowadays generics are also available. Nowadays generics are also available, which are cheaper than the originals. Naturally.
The catch about the generic of dabigatran, we are not sure about the reversible agents being available for it, even though they proclaim that they are going to give it, but we are not sure whether they are going to give it. So that is one catch-22 situation, because they have to procure through the original company only for that brand, edaravimab.
Yeah.
That is what, even though the proclaim, it is difficult.
But question is, how many patients do require reversal? Or we can just give plasma and tide over the crisis.
See this will come only if postpartum CVT, there is definitely no, because there is no evidence of NOACs are contraindicated in lactation. So we have one subset of patients where male CVTs or elderly CVTs or some unprovoked or this one. So where we have an option. So postpartum CVT, as on today, it's only warfarin. NOAC is not indicated. So lactating this one. So that we should be a little more. So we have one subset, but majority what we see is postpartum.
And also you must remember about the APLA syndromes, because as we all know, for APLA syndromes, NOACs are virtually ruled out, because this is a strong opinion across the board that whenever it comes to APLA syndromes, once we have this, then there's no question about putting them on NOACs. So I think renal failure, APLA, and all the other factors put together, I think should take a collective decision.
NOACs, the other advantage is in the OPD practice, when the patient refuses to get admitted, they refuse to take heparin, they just come with headache and a single vein occlusion. One can OPD based only, we can start NOACs and then see. So that also has been done in our OPD practice. So it will help in that.
Onset of action is quite rapid, and don't need to wait for 5 days to INR to pick up and all in NOAC. That's an advantage.
Yeah, that's true.
So with this, I think we'll close this debate and take a few questions. I think the questions have been pending for quite some time. I would request, I I'll just go to one of the questions here. Overall, NOACs are considered safer than vitamin K antagonists. OCP, purpural CVT, most unprovoked CVTs without APLA likely may benefit with. So may benefit with NOACs. So again, I think this point has been discussed. I think this point has been discussed. We can go to. Since we know the coagulation.
I think.
Yes, sir. Yeah.
One question was asked, multiple times. The target INR. I would like Dr. Dayanand to answer that. I think target INR. A lot of people have asked about the target INR.
Majority of the studies, it's 2 to 3. So again, in the clinical scenario, we can keep a higher INR if they have a recurrent DVT, recurrent symptoms. We can keep it in the 3 to 3.5. Like for example, just like in a heart valve replacement, we give a more INR, we give more INR. Like that, we can increase the target in such situations. So most of the time, it is 2 to 3.
Okay.
Another practical point is anybody's INR above 1.5. We have seen, I think the target mean time is majority of the time it will not be there. That is the back of the warfarin, that mean INR. Anything above 1.5, they are reasonably okay. In the clinical practice, what we see majority of the time 1.6, 1.8, but they don't have any reason. So what I usually tell my patients above 1.5, it is okay, but target is, as Sir was telling, 2 to 3, around 2.5. So we should not get panic if they get 1.5 or 1.6 and all. We should not. We can increase it, titrate it.
1.86. So we don't need to readjust finally.
So this another practical question here. Do we need to monitor PTINR for patients on NOAC? I would request either Dr. Saravanan or Dr. Nikhil to take this. Do we need to monitor PTINR for patients on NOAC?
Definitely no, but in certain situations, like patients have come with some problems or like some bleeding problems, or they are planned for surgery, any elective surgery, only then we will do it, but routine monitoring is not required.
To add to that,
Factor 10A activity is assay is done. Factor 10A assay is done for people on NOAC.
So one is factor 10A and other is APTT levels. I think we don't do a PTINR levels in these patients. We can do APTT as an indirect marker for so understanding what's the coagulation status as of now. So anything between 1.5 to 2 times the baseline APTT is considered that the patient is adequately anticoagulated. So this is one of the indirect things that you can go by when patient comes to the emergency. And in those patients, we may not do a PTINR. Another question, I think quickly we can take it. In pregnant patient on her second trimester developing CVT, can we give LMWH twice daily up until the patient delivers? Or do we just give it for 5 days and then what drug do we shift it to? So this should be a popular question with the gynecologists. So in a pregnant lady,
usually what we practice, I have few patients. We will also first trimester definitely low molecular weight heparin twice a day. Once anticoagulation is reached and patient become asymptomatic, you can maintain them on once a day as a maintenance. So in second trimester, you can switch over to the warfarin and keep the INR. At definitely the last month of the delivery, one can go back to the low molecular weight heparin. So this is the ideal way. Here also we give option if the patients can afford, willing, definitely low molecular weight heparin can be continued throughout the pregnancy. Other thing is we should not use the multi-dose vial. So we get deltaparin multi-dose vials. So multi-dose vials, because the additive is a contraindication in pregnancy. So they have to take the pre-filled syringes only every day. So that is one thing, because this is all we are learnt in a hard way, that multi-dose once we give, it is known to cause the problems. So we can give the offer this one, ideally low molecular weight heparin, but second trimester we can switch over to the WARF, as because it doesn't cause much problem in the once the organogenesis has happened.
Okay. Another question here is in hemorrhagic venous infarct, should we continue anticoagulation? So now I would request Krishnamurthy sir only to answer this.
There is no issue at all, I think. If hemorrhagic infarction or a massive, there is no need to no, there is all the need to give heparin and subsequently oral anticoagulation. I think this story, I think we must listen. We were students. We never had started using heparin. We were only using serum mannitol as an anti-epileptic medication. Subsequently, slowly evolved. It evolved. And in 1990s, there's a landmark paper by Ian Paul in Lancet, who he studied in 20 patients with CVT, puerperal and non-puerperal, using the conventional of heparin, what cardiologist 1,000 units per hour infusion, and he found no change in the hemorrhagic infarctions. Problem with using massive dose of heparin also. Subsequently, we saw Dr. Professor Nagaraj, D. Nagaraj, I think he forgot to mention, he used 2 trials. One was 5,000 units of conventional heparin IV 8 hourly, beneficial. Subsequently, reduced to 2,500 8 hourly, IV or subcutaneous, all beneficial. Then there is no problem with heparin. We started using heparin then only. I had 3 theses on this topic. And with massive hematomas, we are using heparin, same dose of what Dr. Nagaraj was using. That was useful. There was no problem at all, no complication at all. Then we saw the evolution into this normal cleaved heparin versus unfractionated heparins. Then we have gone on to that phase, and subsequently we have gone on to this phase where we are debating about this NOACs and conventional anticoagulants, oral anticoagulants. This is the story of this CVTs.
Yeah, I wanted to mention Professor Sharma was the postgraduate student who did the thesis. I think it is widely quoted, Dr. Nagaraj and Dr. Sharma, that 5,000 BD, subcutaneous BD. Sharma sir's thesis was the heparin in CVT. So, we have also observed even the low dose heparin. I had patients where they have a bleeding, massive bleeding in the brain, but they also have aortic thrombosis and all. So just even a low dose of low molecular weight heparin, just till, see, it's basically we should understand you give heparin to prevent a new clot formation. The body itself will start anti-fibrinolytic system. We are just tilting towards anticoagulation. So no need to give high doses. Even the low doses of anticoagulation in CVT, in a massive bleed, if you see, what we are doing is 0.4 or 0.6 OD we are giving. That also we have found beneficial. The bleeding has definitely not once. So if you are scared, if the big bleed, don't withhold, at least give a low dose of heparin. That is definitely beneficial. It will be there.
Thank you for a nice question and answer session. I think we can move on to the last talk of the day. I request Krishnamurthy sir to kindly invite Dr. Sharad.
The next topic for discussion is the role of mechanical intervention. I think none other than Dr. Sharad Kumar. He needs introduction. He is a very popular neurointerventionist, blue-eyed boy of Bangalore probably. Dr. Sharad Kumar, please take over.
Thank you, sir. Thank you for the introduction. At the outset, I would like to thank BNET for this invite. And without much time, I will directly go into the endovascular intervention in CVT and what we have learned till now. As we all know, we all discussed till now, initial and the treatment of choice is systemic anticoagulation. However, however, with anticoagulation alone, large and extensive thrombi are unlikely to dissolve. Approximately 1/3 of the patients with severe presentation have a risk of incomplete recovery. Endovascular intervention is an alternative option for patients with neurological deterioration despite the use of anticoagulation. The diagnosis of CT is largely made based on the clinical suspicion and imaging picture. The clinical presentation of the CVT is protean and often missed. And then we follow a strict imaging protocol. Either it is CT based or MR based. Generally, we go with the MR based protocol more widely because of the wider availability of MRI. The important thing about MRI, we have to understand a bit about diagnostic radiology as well, is that MRI should always include MRV, and don't forget to review the SWR T2 star images, because isolated cortical vein thrombosis is only diagnosed with SWR GRE sequences. You cannot diagnose with routine MRI sequences nor with the MRV, because it is isolated cortical vein. And contrast enhanced MRI, do a contrast with the volume sequence, the 3D sequence, because this is mainly indicated when we have a confusion, that the routine confusion, whether this is hypoplastic or a thrombosed vein, especially on the left side system. And 3D sequences would be very useful, because you can see a contrast in that hypoplastic vein, unlike a filling defect in a thrombosed vein. So I find it very useful in differentiating hypoplasia versus thrombosis. So how it is different from the arterial stroke, especially with the intervention perspective. As we all know, venous system is a flow flow system, and the clot burden is huge, unlike arterial strokes. So perfect angiographic picture using endovascular treatment is not at all possible. Like the M1 is occluded, you go and open it and nice M1 is seen. This is not possible in endovascular treatment with venous thrombosis because of the obvious reasons. And the effectiveness is not assessed with is not assessed directly, it is assessed indirectly using definitive parameters like improvement in the cerebral circulation time. Normally we know how the cerebral circulation time is, that is the time from the appearance of that terminal ICA to the first cortical vein, the duration. Usually it will be 5 to 6 seconds. So we have to see that what change we have done in the cerebral circulation time at the end of the procedure, and of hanging veins. I will show you the pictures, then it will be easier to understand. And one should remember that endovascular treatment is a salvageable therapy. It's a complementary to medical treatment and decompressive surgeries. It is never a primary indication. And there are several papers on endovascular intervention in CVT. Exact indication for neurointerventional procedure in CVT requires further validation. There is clear-cut guidelines. Still, it is at the class of evidence is 2BC evidence is there. So how we are going, what the majority of the literature say is, when there is a clinical deterioration or progression of the infarction or the thrombosis despite adequate anticoagulation. Nobody says what is the duration before declaring the anticoagulation treatment failure. Nobody knows that. It is unknown largely. So generally we wait for 3 to 5 days, but no whether we should wait or should take a clinical decision based on case to case wise. If the patient is in severe stupor or comatose presentation at the beginning itself, the initial presentation is very bad, or a deep CVT progressing rapidly. So these are the major indications currently. The major contraindication to anticoagulation such as bleeding disorders or thrombocytopenia or recent GI bleed can also be considered for endovascular treatment. So there are several ways to treat. There is no guidelines to say what is the best procedure. It is always the combination which works. As you see in this picture, we can do direct aspiration similar to the ADAPT technique, that is a contact aspiration. Go to the foot end of the clot and aspirate using a 20 cc suction pump, which is widely available with our arterial stroke ADAPT technique, the Panama pump, or do a mechanical thrombectomy with a stent retriever. Isolated stent retriever will not work with huge clot burden. So it has to be like a Solombra technique. You will be using contact aspiration catheter as well as stent retriever together so that you can increase the efficacy of the debulking of the clots. And direct thrombolysis with local injection of thrombolytics. This is the most popular one, which is the first one to begin with, which I will be talking about that later on. And the other is the using a dedicated catheters called angiojet catheters, which have multiple side walls, and it where you inject a saline in a force and disintegrate the clot and aspirate it. So the clot disruption techniques. And the other one is mechanical suction with balloon stabilization catheters, like the last one, where you inflate a balloon by crossing the clot and just pull out mechanically and debulk the clot mechanically, especially using the Swan-Ganz catheters. So I will talk about the intrasinus thrombolysis. We all intrasinus thrombolysis is direct delivery of the thrombolytic agent into the clot using appropriate catheters or devices. It can be the microcatheter or dedicated catheters like angiojet catheters, which are pretty bulky, difficult to navigate, a little bit scary as well. We use generally microcatheters to deliver that. The most common agent used earlier was urokinase. Now more and more people are using TPA. So how do we use urokinase? A bolus dose of 1 lakh international units are generally given if there is no large hemorrhagic infarct. It is after the bolus dose, we leave the catheter there and start an infusion at the rate of 40,000 to 80,000 international units per hour. We leave this microcatheter in the sinus for 2 to 3 days maybe, and do a check angiogram every 24 hours and take a call based on that. and also see the patient's clinical status and decide. Similarly, TPA can also be used because they have several theoretical advantages over urokinase, a short half-life, 5 minutes as compared to 15 minutes, and better clot lysis with the in vitro clot analysis. So what we do is, there are different protocols, different techniques. Nobody says what's the dose to be used. We give 10 mg over 10 minutes bolus, then 5 mg per hour until the thrombolysis is achieved completely, or 100 mg of maximum limit is reached over a period of 2 to 3 days. Alternatively, few people, which is very popular, is to use 1 mg bolus every 2 centimeters. Initially, go to the distal end of the superior septal sinus if your SSS is involved, and keep on delivering 1 mg of bolus over 5 minutes every 1 to 2 centimeters. Keep on pulling the catheter, irrigate the clot all along its length, and then again leave the catheter there. Continue the infusion 1 to 2 mg per hour for next 48 to 72 hours. So there are several literatures quoting like how they have done previously. This is for the urokinase. You can see variable doses, variable protocol. There's no two studies are matching actually over a period of time. If you see the TPA, same thing. There are several protocols. Generally, this 1 mg, 10 mg bolus and 1 mg per hour is the standard which majority of our people follow. And these are different catheters which are used. These are the angiojet catheters which where forcefully the saline is injected through that and macerate the clot and then aspirate through that same side holes. This is the Fogarty catheters that are used for the forceful aspiration of the clot. All these are different devices. But the newer devices, what we use is the same devices, large bore catheters, which we use for arterial strokes. Earlier, older penumbra system was very good as compared to the present. Current, unfortunately, older penumbra system is not available in the present day. The old penumbra system has a separator which used to tease the clot and fragment it, and then take out this and aspirate the clot using a dedicated pump, which is a negative pump which aspirates the clot. And another important technique what we routinely use is using a balloon. We can macerate the clot. We shatter the clots and then use a suction aspiration catheter. When you break down the clot with balloon then it will fragment and you can aspirate it very easily, especially if you are dealing with the cases which have a later arrival. So by reviewing all those literatures which has done a combination of mechanical and chemical, we got several several literature as well. And I will be showing few cases through that. So this was one of the cases which we did in St. John's Hospital recently. It's a 48-year-old man presented to emergency department with headaches since 10 days, sudden increase in headaches past 2 days, 2 episodes of seizures. And the vitals were stable at the admission, and the initial imaging was done at the local hospital, which was referred later on. And this was a CT picture done elsewhere. This was a typical appearance of CVT. You can see the multifocal bilateral subcortical linear flame-shaped hyperdensity is seen. It's a characteristic pattern of CVT, flame-shaped or candle flame appearance, and hyperdense superior septal sinus. T1 weighted images, you can see a subacute T1 hyperintense thrombus distending superior septal sinus. And the gradient are the SWI images showing that same, the congested veins and multifocal hemorrhages, and absent superior septal sinus extending to right transverse and sigmoid sinuses. Initial investigations were normal apart from the high hemoglobin. Standard treatment was given with anti-edema measures. Patient was stable for next 2 days, but he had one more seizures, then started deteriorating. The repeat CT was done. Repeat CT showed expansion of the hematoma, worsening clinical deterioration. Then the mechanical intervention was offered to the patient, and the patient was immediately accepted and immediately was taken to the cath lab for the mechanical thromboaspiration using the penumbra system. We used a 5max catheter, which was available at that time. It's a large bore catheter which used for aspirating the clot from the ICR MCA. Generally, we do both venous as well as the arterial punch in any CVT interventions. Either it will be most commonly femoral artery or the jugular vein direct puncture. In this case, we did a right femoral vein puncture. We went ahead and went into the internal jugular vein and then to the sigmoid sinus and went to the transverse and entered the superior septal sinus. We use a long sheet which we keep in the internal jugular vein near the jugular bulb and take a smaller catheters to navigate the intracranial venous system. And simultaneously, we acquired an arterial puncture and did it for doing a diagnostic angiogram and to guide the procedure further. This is the, as you can see, hardly any veins are visualized. I mean the superficial venous system. The superior septal sinus and the right side is not at all visualized. And there is congestion of the cortical veins or the sylvian veins. This is a long sheet kept in the jugular bulb. This is the O3 wire, 5 wire, thermo wire, which is going into the superior septal sinus. We see that when we pass this wire, the wire should have this shape, U shape or a U-turn, so that the entry is atraumatic. It should not be stuck to the cortical veins and we should not rupture the cortical veins during this procedure. So make sure that this wire is in this shape and then take the wire in this up to the superior septal sinus. Over that, we would take a flexible, the newer catheters are very, very good. They are very flexible. They are atraumatic and they navigate very easily, no struggle at all. Then we take this into the superior septal sinus and then start aspirating the clots. This is at the end of the procedure. You can see significant recanalization has started appearing there and the congestion of the pial veins have reduced. And yes, if you see this pre-procedure, you can see a lot of hanging veins, that is the congested veins here. And this is post-procedure, those veins start disappearing. These are all good signs that the venous drainage has started in the brain, and the cerebral circulation time, which we usually generally in a normal patient, which will be 5 to 6 seconds. In the CVT, we classically see it is 9, 10, 11 seconds or more. And when it starts reducing as you start intervening and start opening the vessels. See this amount of congestion earlier and the congestion now. You can see that hanging veins are all disappeared and more opacification. As I told you earlier, we cannot give a picture perfect result in CVT. We have to just increase the surface area for the anticoagulation to act and permit the venous return as much as possible. So a lot of clots were aspirated, and the post-procedure, the patient was shifted to ICU, extubated after 24 hours. He did exceptionally well. His consciousness returned back. He was moving all the 4 limbs. He was shifted to the ward after 2 days, and he was discharged from the hospital after 5 days intact without any neurological deficits. This was the CT done. You can see that there is no further expansion, no fresh bleed or nothing. And pre-procedure and post-procedure, on the follow-up, his sinuses were almost perfect. So another case, similar case, young lady on OC pills. She had a lot of clot burden here. She presented with headache, altered sensorium to our hospital. And you can see that even in the diffusion weighted images, you can see that clot is showing bright signal intensity. Some authors say that if you see a bright DWI bright clots in the diffusion weighted images, these clots are the ones which have poor response. They are very rubbery. They have a very poor response to routine anticoagulation as well. But this patient started throwing seizures, started developing diffuse cerebral edema, progressing. And since the patient was young and we offered mechanical as a salvageable treatment, we offered an intervention. The patient agreed. And when we did a diagnostic angiogram in a similar technique, which I showed earlier, there was absent superior septal sinus similar to the previous case. Everything was almost exact same picture with a lot of delayed cerebral circulation time. And then you can see a lot of congested veins here. In a similar way, we entered the superior septal sinus. In this, additionally, what we did was we took a larger aspiration catheter called IS68 and did a balloon angioplasty. We had to macerate this. This clot was very rubbery. We had to take a longer 8 centimeter balloon in the superior septal sinus, around 10 mm diameter balloon, longer balloons. Started fragmenting the clots with the balloon plasty, and then using the aspiration catheter, started aspirating. There was some amount of recanalization. Then the microcatheter was inserted there. 20 mg of TPA was given bolus in a graded way from anterior to posterior up to the sigmoid sinus. And then again, the aspiration was done after 15 minutes. Significant amount of recanalization started appearing, and you can see that pre and post procedure there was significant recanalization as well. And this is the 3 months follow-up. Patient did very well actually, and the patient was discharged intact. And some when there is a lot of hemorrhage and edema which is failing, we generally do all these procedures under general anesthesia. We always tell our surgeon that be ready for decompressive hemicraniectomy if it is necessary. We prime the patient accordingly and take these cases, these bad cases, to the intervention. And coming to the review of the literature, what the literature says, this is one of the largest series which was recently published in the JNIS journal. they have studied 17 different cases, different studies, compared and got 235 patients, where the patient, 40% of the patients had the encephalopathy or coma, and these patients underwent endovascular intervention. Despite the poor baseline characteristics, approximately 70 to 80% of these patients achieved good functional independence, and hardly there were less than 10% of the procedure-related complications in this case. Generally, in this case, unlike arterial strokes, we don't do harm in these patients. In generally, we may not be useful for sometimes in a bad cases, but generally the complication rates are very less as compared to ischemic infarcts. And there is only one trial, which is a randomized control trial, prospective randomized double-blinded control trial, which is called TOAC trial, which was published recently, which was a neutral trial. The drawback of this trial was that totally this study was conducted in Europe and China. There were 67 patients which were recruited. 33 were to the intervention arm, and 34 patients were for medical management. And the case and the follow-up was for 12 months. And the numbers were very, very less. Even in fact, in their own publication in the JAMA, they say that the trial is very small, they could not conclude. But the results were very neutral. It was not either favoring endovascular or conventional treatment. There are no data to guide when to choose hemicraniectomy over endovascular management, or when and how to combine them in treatment, treating the patients with severe thrombosis. Still, the guideline is open. We decide based on case-to-case basis. So to conclude, medically refractory CVT is a life-threatening situation. Newer endovascular approaches are promising and need to be utilized with careful patient selection criteria, and larger randomized trials are needed to further confirm the efficacy of endovascular treatment for refractory CVTs. Thank you very much. Any questions or anything?
Fantastic presentation, Sharath.
Thank you, sir.
I mean, I don't have much experience in terms of medical. This is an eye-opener for us. But the recovery was really dramatic in our patient. So
Yes,
I think that made me feel that I think, I mean, it's one case or two cases are not enough to give a sweeping statement. But the recovery made me feel that I think missed out on a lot of patients earlier using this thing. So probably it also gives us some window, unlike arterial stroke where the window period is very, strict and very short. Here, at least you can look at the options always. I think we need to consider that. That's what I felt, that even it is 1 day, 2 days late, you can watch it over and then have that option always kept in mind rather than losing out patients and all. So I think that's what I felt.
Fantastic talk, Dr. Sharath. I think I agree with that. There's a similar question what Dr. Guruprasad just now was addressing. Is there a time window to thrombolize for venous thrombolysis like we have for arterial strokes to get the maximum benefit? So I would like to, Dr. Sharath, only to take this question. So is there a time window generally?
Yeah, I reviewed all the literature, and as per the literature review, there is no definitive time window. Nobody says that you have to try a trial of 3 days, 5 days or anything. It's a vague explanation everywhere. Failed anticoagulation, aggressive in spite of adequate anticoagulation, deep system involvement. But there is no clear-cut time guidelines. Generally, it is based on case-to-case basis, and 3 to 4 days is a reasonable good time to wait and then take a call.
Dr. Sharath, other question is, if you delay further, what is the chance of sucking it out or lysing, because the thrombosis get organized?
Yes,
so
sir.
the intervention aspect, actually, what is the practical problems in, say, somebody is waiting for 5 days, 6 days? And then another question is, if somebody has got a superior sagittal sinus thrombosis with persistent headache, like a papilledema and all, they come 2 weeks down the line and impending, there is a vision problem.
Correct.
So in those cases, does thrombolysis help? Like a BAH presentation of a CVT with impending vision.
If you see the clots on T2 weighted images, if they are T2 hypo or flare hypo rather than hyper, which we commonly see, they are the one clots which respond very good both for intra-sinus chemical thrombolysis as well as for mechanical aspiration. As they become more brighter and brighter on T2 weighted images, they become more firmer and they are very resistant. They work better with. That's why sometimes we have to use balloon plastic to open it. Can't even pass a wire to macerate them. So we have to use a balloon forcefully and we have to aspirate mechanically. So more of mechanical issues when the clots are more organized and firmer. So earlier, always definitely theoretically, there is a lot of advantage to intervene in early stages for 7 days. After 7 days, more challenging, we have to put more efforts to break the clots.
One question is about whether when you consider local in situ thrombolysis versus using techniques of mechanical thrombectomy. So which are the patients and which is the location of these clots, or what is your selection criteria when you go for an in situ thrombolysis versus a mechanical?
For the deeper system, especially the straight sinus and beyond, we can't use mechanical aspiration. It's purely the chemical thrombolysis. You can't take into a balloon or bigger aspiration catheter into deeper system. So you can go up to internal cerebral vein with a microcatheter and inject a chemical urokinase TPA. So no mechanical devices to be used in deep system. In superficial system, superior sagittal sinus or the transverse sinus, both very well. Always it is a combination. Earlier, 4-5 years back, we were not aware of these aspiration catheters. We had only balloon or just aspiration with smaller bore catheters. Now larger bore catheters are available. Now we have experience with TPS, how to use that. And newer devices, more flexible, easy to track, no trauma. So for a superficial system, it's a combination which works better than rather than isolated thing. If there is no bleed, only I would like to leave a microcatheter there and start a TPA or a urokinase, depending upon the case to case. And if there is large hemorrhagic infarct, if you are anticipating surgical intervention, then I personally feel one pure mechanical aspiration rather than using TPA or urokinase would be better.
Okay. Thank you. When can we start NOACs post thrombectomy, or would you suggest LMWH on a regular basis post thrombectomy? So this question, I think any of the panelists can take this. I think Dr. Nikhil, can you take this question? The question is, when can we start NOACs post thrombectomy, or would you just suggest LMWH post thrombectomy?
I would like to continue low molecular weight rather than NOACs, because we don't have, because even when the patient is going for thrombectomy, it indirectly says that probably patient is more severe. CVT risk is more, CVT risk score is more, or NIHs is more. So I would like to continue on low molecular weight heparin rather than using NOACs straight away.
Okay. The next question is, what are the guidelines for radiological follow-up in CVT? I think Sharath should be able to take this question. Guidelines for radiological follow-up in CVT.
Yeah, follow-up in CVT we do after anywhere between 3 to 6 months. The imaging protocol is the same. We do MRI with MRV and with the previous. So imaging timing is more important. We generally avoid between 3 months unless otherwise it's indicated. After 3 months, anywhere between 3 to 6 months.
One other specific question is, what are there any guidelines for deep CVT of anticoagulation or any the treatment? This one, are there any criteria or anything which is there for as a guideline for deep CVT?
You are asking regarding medical or intervention thing?
I think it's a general question, but I think regarding intervention would be more apt.
Yeah. So many literature says that in a deep CVT, in a patient presenting with a bad GCS less than 9, or as Nikhil showed the scores, CVT score more than 5, we can directly take deep CVT for mechanical, chemical angioplasty or chemical ICs. But till now, isolated deep CVT, I have not personally treated as such, as not taken, but would wish to explore that in future. In a young patient with a rapid deterioration, isolated deep CVT doing not very well, it's easier to go and thrombolize with a microcatheter in straight sinus or this one, internal cerebral veins.
So patients presenting with low GCS with an extensive CVT, which includes a deep CVT. So would you, presenting low GCS, would you consider this patient for early intervention itself?
Yes. That's what they say. Early intervention in such cases.
Okay. Thank you. And I think there was one question. I don't know. This question was about I think hemorrhagic disease of the newborn. I think somebody has answered this question. What about hemorrhagic disease in the newborn? When do we shift to warfarin? So this is the question. I can put it to any of the panelists. If anybody can take this question. I think.
You are muted.
I had a question for Sharad.
Yes, sir.
So you're talking about when decompression versus mechanical. So I think once the infarct develops and there is increase in size of the venous infarct and causing thing, then the focus shifts. It's much more, reduce the edema and all. I think the thrombus shifts from there to the infarct.
ICP management.
I think ICP management and all. So I think there's also one of the indications where if you seeing the developing infarct, like in our case, the initial CT was normal, then the venous infarct started appearing. I think that also could be taken as an indication that there is a thrombus, extension of the thrombus and probably worsening. Maybe that is also an indication for mechanical and or intrasinus thrombolysis. What do you say?
So in one of the case, we did mechanical as well as shifted the patient to OT and did a bilateral decompression as well. That saved the life. So that option also should be kept open when we are intervening, because they are generally the bad cases which we take up.
So one question I want to ask to Sharad sir.
Yeah.
Suppose a person develops this fistula, AV fistula, while being on the treatment for CVT. So how radiologically we should follow that patient, and any treatment guidelines?
Yes,
that is different from the conventional CVT. So
correct. So if a patient of CVT developing dural AV fistula, they say in a mean time of 2 years, they generally develop. Very few patients develop. When we suspect dural AV fistula and imaging, especially if you do a DWI or a angiogram, you will easily pick up it. You will not miss, unlike earlier times. So when you suspect a dural AVF, it's mandatory to evaluate it with the DSA, because the grading of the dural AV fistula will decide whether this case needs further follow-up or need to intervene. So major thing what we see in a DSA is whether the antegrade flow in the venous system is preserved or it is a retrograde flow. When you do a angiogram, for example, if you inject a ECA, if your fistula is filling retrogradely into superior, rather than draining superior septal sinus into the transverse and sigmoid, if the fistula is retrograde, filling the transverse superior septal sinus, then emptying through the cortical veins, reverse direction, against the physiology, then these are the cases which we have to intervene. And any dural fistula directly on the cortical vein are associated with venous varix or a spinal venous drainage. All this pattern indicates that they are high risk dural AV fistulas, and it has to be treated immediately. Then at that time, if the patient is on anticoagulation or anything, we just stop it and offer an intervention and close the fistula. And post closure of fistula, we generally don't continue anticoagulation in such cases. We treat the fistula and abolish the retrograde flow. If it is antegrade, if there is a fistula, still antegrade flow is there. They are called as benign and DAVF, and we don't treat them unless there is a retrograde flow.
Thanks.
There's one more question. As Professor LKM summarized, we have come a long way in the management of CVT. Do you foresee a stage where early endovascular treatment is the preferred method of managing CVT? Again, I think Sharad would be. I mean, would it come to a stage where mechanical thrombectomy has come in arterial strokes? Will that happen to venous strokes? Is the question.
Probably not. At least because overwhelming majority of the cases do respond very well to the conventional treatment. We have to pick and choose, preserve this procedure to selected cases rather than randomly doing and causing more harm sometimes. So I think we have to select this case. There should be a less threshold to offer this treatment. We should explore this treatment because of the newer devices coming up, newer larger bore catheters, easy to navigate, less procedure related risk. Ideally, we should have a good randomized control trial in our country rather than, because the Western countries that did a trial, they could not get more than 34 patients. Our countries like us should do the random give this answer to the world.
Actually, I was coming to that. Since now everyone has some experience, all the interventionists, I think you should pull the data and at least publish our retrospective data, and then later we can look at institutional based prospective trials and all.
True.
In fact, the trial what you put the trials that was by Dr. Anand is from KM.
Correct. KM has the largest series.
Cases, KM has the highest series. I was doing my MD during that time when the trial was going on, so we didn't have much idea at that time, just recruiting patients. But I don't think they could come out with any guidelines regarding who are the patients who will benefit and all. So that was the problem.
Sharat sir, I have one question for you.
Yeah.
You are telling about one patient you did thrombectomy with immediate bilateral decompression. So
correct.
I also had one similar patient some few months back. So he was a young patient who had a extensive, almost superior sagittal sinus, bilateral transversus was thrombosed, and just within 24 hours he had rapid deterioration. So during that time, instead of going for a thrombectomy and then bilateral decompression to prevent coning, so I actually went for bilateral decompression directly rather than a thrombectomy.
Correct. Okay.
So whether that will make any difference, like initially, explaining to the patient, okay, we'll do thrombectomy and then do a decompression rather than just doing a bilateral decompression straight away. So whether that will make any difference, first going for thrombectomy and then decompression, or straight away going for decompression, that will make any difference in the clinical setting.
See, theoretically, doing debulking the clot and then sending the patient to decompression, theoretically we have an advantage that doing the brain better and simultaneously doing the decompression. Yeah. So even post decompression, your medical management also works well if you have clot or increase the surface area there. The recovery will be quicker than at that time. Definitely, because it may not take much time. You are not wasting much time here. It may take hardly an hour or two. Unlike arterial stroke, we are not wasting much time here.
Other practical point is when you do a decompression, neurosurgeons are very scared to start anticoagulant. So in that way, we will be losing time, because once you do decompression, you can't give anticoagulation. We had problems. They used to stop and the patient used to clot. So I think best thrombectomy and then decompression, both will be required. I think the cerebral edema, which is coning, and as Sharat was telling, we remove the clot burden so that the CVT doesn't progress, because otherwise they will start oozing from the wound site when you start giving anticoagulation. So this is a little difficult situation. So we have to balance it and then see. I think first thrombectomy, then decompression will be little beneficial.
In the same GA, we can post the patient there directly.
Yeah. But they should be aware that those are different. One is management of ICP, another is management of the cause for the ICP.
So Sharat, as a technique, arterial thrombolysis, mechanical thrombectomy in arterial thrombosis versus venous thrombosis, what's the technical difficulty and what is the learning curve?
Yeah, because in venous, in fact, the clot burden is so high. Like last case, the patient was AB negative. 8 was the hemoglobin. We keep on aspirating the clot. Anesthesia people started shouting, you have already aspirated 250 ml of blood. How much you have to aspirate? AB negative, there is no AB negative available currently. So when you do a mechanical aspiration, you lose a lot of blood, especially anemic and females. These are unique challenges for the venous infarcts. We don't see such things here. And during the injury, especially the iatrogenic injuries, which happen during the arterial stroke, are fatal. You cause SH, you perforate, wire perforation. All this venous intervention is a relatively crude procedure. It doesn't take much skills to do venous procedures as compared to arterial. There, the time and the skill matters in arterial stroke. In venous, it is mainly a mechanical, it's true plumbing job in the venous. Debulk the clot as much as relax. Don't rupture the cortical veins. It's difficult to rupture unless you are very new to the procedures. Otherwise, you have multiple options in venous procedures, unlike arterial. Time, plus you have chemical, you have balloon, you have aspiration catheters. So relatively, it's easier. and it will be more safer to do venous infarction. I will be more relaxed when I'm doing venous intervention than arterial interventions.
I think it was a wonderful session. A lot of questions, very interactive. I think I would hand over this dais. I think remaining questions can be taken either on the email or in a subsequent. The speakers can just answer them. I would hand over the dais to Dr. LKM sir to to give the concluding remarks and also to tell us about what is his experience about this webinar. Thanks.
Thank you. Thank you, Sharath. It was an exciting talk.
Thank you, sir.
Only hope your tribe increases. Your people increases, and they are peripheries like my case and Shumaga, Hubli, like that. Like when I did my DM, I was my mentor pushed me to periphery, and Dr. Shivaram Krishna was the one who went to Shumaga, and I came here to Davanagere. Like that, I think you should mentor many people and push them away to peripheral places. It will be useful to us. Exciting talk. Thank you. Thanks a lot.
Thank you. Thank you.
You might also have to clone Sharath multiple times. So that is a little difficult thing to do.
Only we hope his tribe increases.
Yeah, his tribe
his people increases and they are pushed to peripheries.
Absolutely, sir. With this, I think I would invite Mr. Ganeshan to, I think, take over the stage and give his concluding remarks.
I think I have no words. I think it was very well done. And of course, I am a layman. I am not a doctor, but still, I found it so interesting. It was a great program. I'm sure the panelists as well as the participants must have enjoyed this scientific feast. And we look forward for more such programs, sir. And I thank the entire team for having, done such a wonderful program. And we look forward to be a part of more such programs. It also gives more meaning to us to be in this industry and to be a part of such programs. Thanks, Dr. Guru Prasad, Dr. Krishnamurthy, Dr. Amit, and all the others, Dr. Mayank, Dr. Saravanan, and Dr. Nikhil for wonderful talks. Thank you, sir. Thanks a lot. Very good day to you. Dr. Guru Prasad?
So I'd like to thank Amit for wonderfully moderating the session, today's session.
Yes.
Special thanks to Dr. Krishnamurthy for joining and sharing this session today. His words of wisdom always will carry with us with all this COVID and all of things. I think everyone has a lot of baggage of emotions and all during this time, but blessings and wishes from seniors like Dr. Krishnamurthy will carry us forward. And also thank all the speakers, starting from my colleague, Dr. Mayank, Dr. Saravanan, Dr. Nikhil, Dr. Harish. Great talk by Dr. Sharath as usual, Dr. Dayanand. So I think all this, all the speakers made this beautiful session lively and a lot of interaction. I think this session had the highest number of questions and interaction as compared to the other sessions. I think we keep it going this way, which will make this much more interesting. Thank you, one and all. And all my colleagues from BNET, Dr. Umashankar, Dr. Raghunandan,